Right. And this is Clinical Updates in Breast Oncology with Emily Ray, MD, MPH. Dr. Ray, thank you so much for being here today.
Oh, thank you for having me.
Absolutely. We are thrilled. I'm just going to put that up for a minute and let folks know that we've got the regular bio there, but we're doing our sort of our David Letterman style top five. We're not going to do top 10. We'll do top five. Five, Emily Ray, MD, MPH, is a medical oncologist with a clinical focus on care of patients with breast cancer. Her research focuses on improving cancer care quality and understanding healthcare utilization among patients with advanced cancer. Number three, she graduated from the University of North Carolina at Chapel Hill School of Medicine in 2013. Number two, she then completed her residency in internal medicine at Duke University in 2016. And number one, she trained as a hematology oncology fellow at UNC until 2019 when she joined the faculty at UNC. And we are very glad to have you here. Dr. Ray, what's one thing we should know about you outside of your professional bio there?
Well, I think we're entering my favorite time of year in Chapel Hill. So I love spring on campus. The pictures behind me are pictures that I've taken when walking on campus with my family and my dog. So I think this is a great time of year to be here.
Absolutely. Thank you so much. I mentioned poll everywhere, so that's that first slide. We're going to first poll everywhere question. Breast cancer can affect both men and women, true or false? We try to make this first one kind of a softball just so that it's easy to get the feel of poll everywhere if you've never used it before. There's our disclaimer. Just need to show that, but we can move on. And now we've got the question for real. So breast cancer can affect both men and women. A, true, or B, false. Again, these are all anonymous. Really appreciate all of you being here today. I know you're busy. Thank you for taking time out of the day to join us. And thank you to Dr. Ray. How are they doing on that first question?
It looks like everyone nailed it. So you're exactly right. Breast cancer can affect both men and women.
All right. Thank you. And with that, clinical updates in breast oncology, I'll turn it over to you, Dr. Ray. Thank you so much.
Great. Thank you so much, Tim, and thank you all for joining today. I look forward to talking to you today about clinical updates in breast oncology. It was pointed out to me that it's actually been a little while since we've had a breast cancer talk, and so some of the information that I'll cover today actually goes back over the past couple of years. And so we will start today by talking about early stage or locally advanced breast cancer, some of the updates in that space, and then we'll move on to talking about breast cancer, including some new therapies and some of their associated toxicities. And so as you very well may know, in the United States, breast cancer remains the most commonly diagnosed cancer among women and is the second most common cause of cancer death in women, only behind lung cancer. And as you can see summarized in this U.S. data from SEER, the number of new cases of breast cancer have remained relatively stable over time, but we can see improvements in death rates over the past 30-plus years. And so I'd like to first start by talking about high-risk early-stage disease, where new therapies can reduce the risk of breast cancer recurrences, and in doing so can improve overall survival. And so we'll talk first about the Monarch-E study, and we'll look at the schema there for this study. You may be familiar with this, but this was a study of patients with hormone receptor positive breast cancer, HER2 negative, that were node positive and deemed high risk. Patients were deemed high risk by having either 4 or more lymph nodes involved by the cancer, or if they only had 1 to 3 nodes, they would be considered high risk if they had grade 3 disease, a tumor greater than 5 centimeters, or a Ki-67 greater than or equal to 20%. And so these high-risk patients were randomized 1-to-1 to receive the standard adjuvant endocrine therapy or adjuvant endocrine therapy plus abemaciclib dosed as 150 milligrams twice daily. The primary objective of this study was to examine invasive disease-free survival. And so what we see from this study is that the addition of abemaciclib to adjuvant abemaciclib the addition of abemaciclib to adjuvant endocrine therapy for these high-risk patients does lead to an improvement in invasive disease-free survival with a hazard ratio highlighted on the right of 0.66, or a 33% reduction in the risk of developing invasive disease. We also see from this study on this next slide that these improvements were mostly driven by improvements in distant recurrence. So the addition of abemaciclib leads to a 34% reduction in the risk of developing a distant recurrence. And encouragingly in this study, there were not really any significant new safety findings compared to the data that we had already seen from the use of this drug in the metastatic setting. One thing that has emerged over the past couple of years, if you look at this table on the far right, it does appear that there's an increased risk of venous thrombotic events in patients on abemaciclib, and so I think that is an important new finding. This is especially relevant to patients in the adjuvant setting who are premenopausal and might have otherwise gone on tamoxifen for their adjuvant endocrine therapy. I am now avoiding the combination of tamoxifen and abemaciclib in these high-risk patients and would instead favor use of ovarian suppression plus an aromatase inhibitor to avoid the compounding risk of VTE. So I think the key take-homes from the MONARCH-E study are that for high-risk patients, adjuvant abemaciclib for 2 years improves invasive disease-free survival and distant recurrences in high-risk patients. It does add toxicity, of course, compared to endocrine therapy alone, and we are still awaiting maturation of the overall survival data to see to what extent this improves long-term outcomes. But this is the new standard of care. And so looking at this first polling question, so which of the following patients should be considered for adjuvant abemaciclib in addition to endocrine therapy? A patient with ER-positive, PR-positive, HER2-negative disease that is a pathologic T1A in 0. B, a patient with ER-PR-positive, HER2-positive disease with a T3N1 tumor. C, ER-positive, PR-positive, HER2-negative with a T3N1 tumor. And please use the polling system to respond to this question. Oh, I jumped too soon. Let's see. Give you a minute there. Thank you. Those answers are coming in. I tipped my hand, but I'm sure many of you would have gotten this either way. Thank you for your responses. So I'm seeing the overwhelmingly majority selecting answer C, which is correct here. The reason that answer A would not be correct, that tumor is too small. It doesn't meet the criterion for high risk in the MONARCH-E study. Answer B is actually a patient with HER2-positive disease, and so those patients have not been proven to have any benefit of abemaciclib. So C is correct. That patient would have met the inclusion criterion of MONARCH-E and is appropriate for adjuvant abemaciclib. Thank you for your participation. So I think changing gears a little bit, looking at HER2-positive early stage or locally advanced breast cancers, I think notably there haven't been a lot of major changes in this space over the past couple of years. One of the most notable changes from 2019 was that we've seen that we can de-escalate therapy for patients with small node-negative tumors. That was the APT trial by Dr. Talani, which demonstrated that using 12 weeks of trastuzumab plus a taxane yields good long-term outcomes. Now I think we're wondering, can we actually safely de-escalate therapy for patients with higher risk tumors now that the HER2-directed therapies have improved so much? And so this is an area of ongoing investigation. We do have a clinical trial open at UNC right now called EA1181, or the COMPASS HER2 PCR study. This is looking at that very question. So rather than giving our standard neoadjuvant carboplatin plus paclitaxel plus trastuzumab and pertuzumab, this study is actually omitting the carboplatin and looking at responses in that de-escalated regimen. And so if patients go on this study and they achieve a pathologic complete response to that de-escalated neoadjuvant regimen, in the adjuvant setting, they would only receive trastuzumab plus pertuzumab. But if they don't achieve a pathologic complete response, then they would receive additional chemotherapy, typically with an anthracycline-based regimen, and then for their adjuvant HER2-directed therapy would switch to TDM1. And so this study is still open to enrollment for patients with large tumors greater than 3 centimeters or node-positive tumors. So if you have anyone who might be appropriate for a de-escalated approach and wants to participate in our study, we'd be happy to see them. And so looking at triple-negative breast cancer, I think the most groundbreaking study of the past few years, of course, has been this study, Keynote 522, looking at the addition of pembrolizumab to standard neoadjuvant chemotherapy. This study was a phase 3 trial of patients with triple-negative disease. The tumors had to be at least a T1C N1 or N2, or if it was a larger tumor greater than 2 centimeters, they were included. And these patients received neoadjuvant chemo plus pembrolizumab versus placebo, and then in the adjuvant setting, they received pembrolizumab versus placebo. And the chemo used in this study was paclitaxel and carboplatin, followed by doxorubicin and cyclophosphamide, or epirubicin and cyclophosphamide. And the primary endpoints in this study were a pathologic complete response at the time of surgery and event-free survival in the intention to treat population. And so let's look at why are we all using this regimen now. We're using this regimen because this study showed a significant improvement in pathologic complete response, and this seemed to be unrelated to PD-L1 status. So there's no recommendation for PD-L1 testing of these tumors in the early stage setting. And we see an absolute difference in path CR rates of about 14%. We'll look at the EFS data here in just a moment, but there was a non-significant improvement in event-free survival. Notably, there, of course, with more drug, there can be more toxicity, so we do see some immune-related adverse events in the group that received pembrolizumab. So these event-free survival data are still immature. They have not yet met statistical significance, but there does seem to be some separation of the curves here favoring the addition of pembrolizumab. So more time is needed to see these outcomes long-term. So I would now consider neoadjuvant chemotherapy plus pembrolizumab to be the standard of care for patients with triple-negative breast cancer and tumors greater than 2 centimeters or with node-positive disease. I think that's pretty well established. The questions that still remain are, what do we do for these patients in the adjuvant setting? And so it's important to note that Keynote 522 did include adjuvant pembrolizumab to complete 1 year of therapy. So what we are typically doing at UNC is if a patient achieves a pathologic complete response, they would continue on adjuvant pembro alone, barring no significant immune-related adverse events. But if a patient has residual disease, the thought process here is to first see if they have any germline BRCA mutation. We routinely perform this testing for patients with triple-negative breast cancer. And if they do have a BRCA mutation, we would combine pembrolizumab with olaparib. And that is based on the data from the Olympia trial looking at adjuvant olaparib versus placebo for 1 year for patients with germline BRCA mutations and residual disease after neoadjuvant chemo. This study did include patients who did not receive neoadjuvant chemo and were receiving adjuvant chemo for large or node-positive tumors and had a BRCA mutation. And what the Olympia trial showed is that there's an improvement in invasive disease-free survival in the group that receives a year of olaparib, translating to a hazard ratio of 0.8 for invasive disease or death. And so that translates to a 42% reduction in invasive disease at 3 years. We also see that adjuvant olaparib reduces distant recurrences by 43% at 3 years. And again, there's a suggestion of improvement in overall survival with some separation of the curves that you can visually appreciate on the Kaplan-Meier curve here, but those data are still immature, so more follow-up time is needed. So kind of how do we synthesize this information? So if a patient's germline BRCA has a germline BRCA 1 or 2 mutation, we add adjuvant olaparib. If they're germline normal, we are typically combining pembrolizumab with capecitabine. That's on the basis of the CREATE-X trial that was published in 2017, as well as other studies demonstrating that the combination of pembrolizumab and capecitabine is reasonably tolerable and safe. And so let's sort of kind of revisit these clinical decisions. Let's look at this question. If you have a 48-year-old woman who has a germline BRCA1 mutation who's diagnosed with a clinical T2N1 invasive ductal carcinoma grade 3, it's triple negative, she receives neoadjuvant therapy per the Keynote 522 regimen with chemo plus pembrolizumab. She has surgery and she has 2 millimeters of residual invasive disease in the breast and 0 out of 3 lymph nodes involved by carcinoma. So what would you recommend for this patient in the adjuvant setting? If you'll please go to Poll Everywhere and answer there. All right. Thank you so much for your responses. It seems like the majority of people are selecting option B, and let's walk through all of these answers together. So I agree that B is the appropriate choice. I would select that on the basis of the fact that the patient has a BRCA mutation, and so the Olympia trial demonstrated an improvement of adding olaparib, and she has invasive residual disease, so she qualifies for that. A is not optimal. It's not entirely off the map because in Keynote 522, these patients only received adjuvant pembro without olaparib, but I don't know that that's really optimizing her available therapeutic options. C is not correct because, again, I'd prefer to use a targeted agent over capecitabine. And then we don't really have safety data for the combination of olaparib plus capecitabine, nor are there any prospective trials studying that in this particular context. And so let's change gears here now and talk about metastatic breast cancer, where we often see our newest therapies kind of coming to the forefront. And so the majority of our patients have hormone receptor positive disease, and in this space, the use of endocrine therapy plus a CDK4/6 inhibitor in the first line is now well established. And I'd like to review some of those data and then talk about the second line setting. And so looking at the available CDK4/6 inhibitors, this table, which was provided with the assistance of my colleague, Dr. Amy Fazo, compares the different CDK4/6 inhibitors in terms of their toxicity profiles. And you see that for palbociclib, one of the primary toxicities is actually neutropenia, and that is also true of ribociclib. Ribociclib carries the additional toxicity of potential QTC prolongation, which is why the recommendation is to monitor QTC at the time of treatment initiation and in the first month. Abemaciclib actually carries a lot of GI-related toxicities, and so, and then also has this increased risk of VTE that we discussed earlier. We kind of joke that abemaciclib is a pain for our patients, whereas the palbociclib and ribociclib is more a pain for the provider, and so many of us favor the palbo or ribociclib for that reason. But let's look at how these drugs compare in terms of efficacy, and this is with all the caveats of the cautions of cross-trial comparisons because these study populations, in fact, are different. But just to get kind of a sense of how these numbers compare, we saw in the Mona Lisa 2 study of ribociclib that the addition of ribociclib, this is the column in the middle, improves overall survival by about 12 months and translates to a hazard ratio of 0.76. So ribociclib has proven overall survival benefits. Abemaciclib actually did not meet its target, did not meet its statistical significance target at the interim analysis with a hazard ratio of 0.75 but a non-significant p-value. Perhaps the most striking findings were from the Paloma 2 study, where the difference between the endocrine therapy alone group and the CDK4/6 inhibitor group was really not apparent. And so I think it's worth looking at the characteristics of this study to try to understand why that may be. Several people have that In the PALOMA-2 study, there was a large number of patients that were lost to follow-up for survival and differed widely between the intervention and control arms. And so it's hard to show differences in overall survival when you don't have vital status for all of these patients. I think another main driver that may explain why the PALOMA-2 study findings were so different from the other CDK4/6 inhibitors is that 22% of patients in this study were early relapses, meaning they had recurrences 12 months after prior endocrine therapy or other therapy, and that was compared to only 2% of the cohort in MONALEESA-2 with ribociclib. And so maybe this is a study population that has more endocrine therapy refractory disease. And so if we look at a subset of the PALOMA studies and restrict it only to those patients who had a disease-free interval of greater than 12 months, seem to still be endocrine therapy sensitive, then we see the average overall survival is actually much closer to the other studies, with 44 months in the endocrine therapy alone versus 64 months in endocrine therapy plus palbociclib. And so that did yield a hazard ratio of 0.74, kind of on par with the other studies. So what do we do with all this information? So I think in the first line, my practice pattern is now to use ribociclib for most patients. It does require EKG and lab monitoring, but we're learning to navigate those logistical hurdles. I do still use abemaciclib for some patients. Certainly if a patient was presenting with brain metastases, I find that to be a nice option given the robust data using abemaciclib in the context of active CNS disease. If a patient has baseline QTc prolongation and thus we need to avoid ribociclib, that might be another reason to consider this. Or if they have baseline or dose-limiting neutropenia, then abemaciclib could be a good choice. I still do use palbociclib for a few patients. Certainly if someone is already on therapy, when the data from ribociclib came out, I did not take my patients off palbociclib and switch them to ribo. We're riding that out. And then if somebody has GI toxicity at baseline, if they have a lot of nausea and abdominal pain, or if they have baseline elevation of their LFTs, then palbociclib might be a good option for those patients. And so I think use of CDK4/6 inhibitors in the second line after progression on first-line CDK4/6 inhibitor is now a situation that we're all facing with the majority of our patients receiving these drugs in the first-line setting. And so to understand whether we should continue the CDK4/6 inhibitors in the second line, we look to the PACE and the MAINTAIN studies. And so the PACE study was a study of palbociclib after first-line CDK4/6 inhibitor and endocrine therapy. This really was a study of palbociclib after palbociclib. There was a requirement to change out the endocrine therapy backbone from AI to fulvestrant, but most of these patients were continuing on palbo, having received it in the first line. And what we saw was that there was not an improvement in progression-free survival, nor was there an improvement in overall survival. In contrast, the MAINTAIN study, which looked at ribociclib in the second line, did show an improvement in progression-free survival with a hazard ratio of 0.57 and a difference in the median PFS. But it's also important to note that the median PFS in both groups was still poor, less than 6 months. Looking at the subgroup analysis, we see that the patients who had received palbociclib in the first line and then were switching to ribociclib on the MAINTAIN study seemed to derive the most benefit from ribociclib. And so in terms of how I'm incorporating this into my clinical practice, if I have a patient who progressed after first-line palbociclib plus an aromatase inhibitor, I would first look to see if they have a somatic mutation. If they have a PIK3CA mutation, then I would switch the endocrine therapy to fulvestrant, and I would also move away from a CDK4/6 inhibitor and put them on alpelisib, trying to give them a targeted agent. But if they don't have a PIK3CA mutation, or if they're intolerant of alpelisib with all of its challenges with hyperglycemia, then I think using fulvestrant plus ribociclib or possibly fulvestrant alone would be appropriate, making those decisions based on toxicity profile and patient tolerance. If a patient progresses after first-line ribociclib plus AI, which I think will eventually be our practice pattern using ribo in the first line, then I again would check for somatic mutations. If a PIK3CA mutation is present, again, I would use fulvestrant and alpelisib. If they don't have a PIK3CA mutation, I would use fulvestrant alone in these patients. I don't think there's really a clear benefit of ribociclib after ribociclib, and no evidence that a switch to palbociclib or abemaciclib would improve PFS. Some of you might be thinking, well, what about elacestrant? This is the new drug on the scene. This is an oral selective estrogen receptor degrader. And this drug was studied in the EMERALD trial, which was recently published. And this trial involved patients with ER-positive, HER2-negative disease who had progressed or relapsed on or after 1 or 2 lines of endocrine therapy, one of which had to have been given with a CDK4/6 inhibitor. Patients were allowed up to 1 prior line of chemotherapy. And so these patients were randomized 1-to-1 to elacestrant, the kind of newer drug, the oral SERD, or investigator's choice of endocrine therapy. And the primary endpoints in this study were PFS in all patients and PFS in patients with an ESR1 mutation. And just remember, ESR1 mutations are a mechanism of resistance that is implicated in 30 to 50% of patients treated with an AI for advanced breast cancer. And so looking at the baseline characteristics of this study population, we see that many of them had visceral metastases. All had received prior CDK4/6 inhibitors that was requisite to enroll in the study. Some had received 1 prior line of endocrine therapy, some had received 2, and a minority of patients had received 1 prior line of chemotherapy. Looking at the breakdown, the majority of these patients had previously received an AI rather than fulvestrant. And so what we saw in this study was that elacestrant outperforms the standard of care endocrine therapy in terms of PFS for a hazard ratio of 0.70. This study, you see kind of a quick drop-off on the Kaplan-Meier curve with progression of disease within the first 3 months. And so when you see that, it means that the PFS, the median PFS, can be a bit misleading. And so for that reason, this study included a landmark analysis at 6 and 12 months for percentage of patients who had progression-free survival. And we see improvement in the elacestrant arm for both time points. And then if we look at those patients, only those patients who had a detectable ESR1 mutation, the benefits of elacestrant are more striking with a clear improvement over standard of care. I think one of the questions that we are increasingly faced with is, should we reach for elacestrant or should we reach for fulvestrant in patients in the second-line setting? So patients who got an AI plus CDK4/6 inhibitor in the first line, they are progressing, and now we have this choice to make. I've shown the slide for only those who have a detectable ESR1 mutation because those are the patients for whom elacestrant is now approved. And we do see that the elacestrant has improved outcomes over fulvestrant in this patient population, but the absolute differences in progression-free survival are relatively small. Again, some of that is misleading because of this early drop-off in that first 3 months. And so looking at the landmark analysis gives maybe a clearer picture of the benefits of elacestrant. And so in the subgroup analysis, we see that the most benefit of elacestrant is seen in those with an ESR1 mutation. And patients who had received a prior line of chemotherapy did not seem to benefit quite as clearly. Another important finding that was presented at San Antonio Breast Cancer Symposium in December was that patients with ESR1 mutant tumors seem to benefit more from elacestrant if they had had a longer duration of CDK4/6 inhibitor in the first-line setting. And so if you look, each of these columns is how long they benefited from the CDK4/6 inhibitor in the first line. And if you look at the middle column, patients who are on first-line therapy for at least 12 months, that is the group that really seems to derive the most benefit from elacestrant. The overall survival improvement has not been demonstrated. with these two curves overlapping. And even when we look at the subgroup with an ESR1 mutation, that did not meet statistical significance. So there's not a demonstrated improvement in overall survival. Looking at toxicities, we see that the group receiving elacestrant had higher toxicity than standard of care endocrine therapy, mostly more nausea, vomiting, and decreased appetite. And so the FDA did approve this drug back in January for patients with an ESR1 mutation and who had progressed on one prior line of endocrine therapy. They also approved the Guardant 360 companion diagnostic device to identify patients who might have an ESR1 mutation, and the recommended dosing is 345 milligrams taken orally with food once a day. And so where does elacestrant fit in then? I think we could consider this drug in the second or third line for patients who have an ESR1 mutation. It does necessitate doing somatic sequencing for these patients after they've progressed on an AI. You can do this with a tissue biopsy, perhaps if you need to pursue a tissue biopsy otherwise, or with a liquid biopsy using the Guardant 360 test or any other kind of liquid biopsy that's available. Importantly, I would not use the baseline tissue biopsy. So if you got a biopsy at the time of metastatic diagnosis, it would be important to repeat this sequencing now because the ESR1 mutation may have developed after the fact. Other things that I consider in deciding whether to use elacestrant would be the route of administration. The oral administration is maybe easier for our patients, but in some patients may present issues with adherence. Versus an injectable like fulvestrant, of course, brings the side effects, discomfort related to the injection. It's clinic administered, so you know if people are getting it or not, but does require time and travel for our patients. The cost of elacestrant is higher than fulvestrant, so that's another consideration. And then I think the main thing for me is the tolerability. So there is more nausea and vomiting with elacestrant. I think we really need to see the quality of life data from the Emerald study to try to understand the impact of these increased side effects on our patients and their day-to-day living. I think we also need to keep our ears open to our patients and our patient advocates about whether they think this drug should be incorporated in the second line. The other thing I look to is how long was a patient on their first-line therapy. If they have a PFS greater than 6 months, this suggests that they still have endocrine-sensitive disease, and they or those who had greater than 12 months PFS even more so. It's a pretty crude measure of endocrine sensitivity, and so we certainly need better predictive markers to make these determinations. So what about after endocrine therapy for patients with hormone receptor positive disease? We, of course, still have our old-fashioned chemo, but we are increasingly looking at antibody drug conjugates in this space. So antibody drug conjugates are these kind of smarter forms of chemotherapy, and they vary by their antibody target, their linker, their payload, and their drug-to-antibody ratio. This is increasingly how cytotoxics and other payloads will be administered in oncology, and there are two proven antibody drug conjugates in metastatic hormone receptor positive HER2-negative breast cancer. So let's take a look at those. So trastuzumab deruxtecan is approved for patients with HER2-low disease. It's an anti-HER2 antibody with a cleavable linker, and its payload is a topo-1 inhibitor, and was approved in HER2-low on the basis of the DESTINY-Breast04 data. This was a study involving patients with HER2-low disease who had had 1 to 2 prior lines of chemotherapy, randomized to T-DXd or physician's choice of chemotherapy, and the primary endpoint was progression-free survival. When we look at the hormone receptor positive cohort of this study, we see that the T-DXd outperformed standard chemotherapy, translating to a hazard ratio of 0.51. We also now have approval for sacituzumab govitecan in the hormone receptor positive space based on the TROPiCS-02 data. This drug is an anti-TROP2 antibody with an irinotecan metabolite payload, and it has a high drug-to-antibody ratio. The TROPiCS-02 study was patients who had hormone receptor positive disease. They had to have received 2 to 4 prior lines of chemotherapy, and the average prior was 3 lines. They were randomized to this drug sacituzumab govitecan versus physician's choice of chemotherapy with a primary endpoint of progression-free survival. And what we see was that there is a progression-free survival benefit of sacituzumab in these patients with a hazard ratio of 0.66. The median overall survival data are immature and have not yet reached statistical significance. And so comparing these two drugs, the TDXD or sacituzumab govitecan, you can see the differing characteristics of the drugs at the top of this table. Looking at the differences between these two trials, it's really important to point out that the sacituzumab group was more heavily pretreated than the trastuzumab deruxtecan group. The trastuzumab deruxtecan, both of these drugs really have some kind of chemo-like side effects, but the TDXD carries the additional risk of interstitial lung disease, which we'll talk about a little bit more in a moment with the HER2-positive disease. And so should all patients with hormone receptor-positive metastatic breast cancer receive TDXD, and if so, when? This slide is courtesy of my partner, Dr. Carey. The data are currently limited to those with HER2-low disease, so it's important to look back. Many of us document in our notes HER2-negative, but now we need to look back and see what the IHC showed and whether they meet the criterion for HER2-low. This should only be considered in patients after one prior line of chemotherapy and is a reasonable choice with excellent efficacy. There are some toxicities to be aware of and try to proactively manage, including nausea and diarrhea. And then I think the really important thing is to remember the risk of interstitial lung disease in these patients. So someone who has an underlying lung or cardiac compromise may be a poor candidate for this drug. Those baseline symptoms could mask or delay the diagnosis of interstitial lung disease and also make those patients less able to tolerate it if they develop it. I would consider sacituzumab govitecan in these patients as well, but later down the line. These patients were more heavily pretreated, and so it is now approved for hormone receptor-positive disease, but patients have to have received at least 2 prior lines of chemotherapy, and if they were treated in the neoadjuvant or adjuvant setting but then relapsed within 12 months, that is considered a line of therapy. And so I'll highlight another trial that we have open at UNC. This is a study involving sacituzumab with or without pembrolizumab in patients with hormone receptor-positive, HER2-negative metastatic disease who've received 1 prior line of hormonal therapy and up to 1 line of chemo. I think this is a nice study for patients who seem to have both chemo and endocrine therapy refractory disease. So an example would be a patient who received curative intent neoadjuvant chemo for high-risk disease, was then put on adjuvant endocrine therapy plus abemaciclib per the Monarch-E study, and shortly thereafter developed a metastatic recurrence. I think this is a nice option to move sacituzumab sort of up the line and also introduce immunotherapy possibly. So let's think through another patient, a 67-year-old with hormone receptor-positive metastatic breast cancer. She has progressed after letrozole and palbociclib, where she had a progression-free interval of about 20 months. She then progresses on fulvestrant plus alpelisib. She was on that for about 6 months. She had somatic sequencing that showed a liver biopsy that showed a PIK3CA mutation and a TP53 mutation. And so what would you recommend for third-line treatment for this patient? Elacestrant, trastuzumab deruxtecan, sacituzumab, or capecitabine. So she's had repeat sequencing, and there's not an ESR1 mutation present. Thank you for your responses. Let's take a look here. So the correct answer here is capecitabine, and I think the main reason is that elacestrant, while it's the newest drug on the scene, it does require an ESR1 mutation, and so this patient has had a repeat biopsy and she does not have an ESR1 mutation in her tumor, so she's not eligible for that therapy. TDXD is a good option for this patient. She does have HER2-low disease, but I would only reach for that after 1 prior line of chemotherapy. She's not yet eligible, but that would be something to keep in the back pocket for the future. Similarly, sacituzumab I would reach for in the future, but not now. It's really proven in more heavily pretreated patients. And so I would reach for capecitabine or any other single-agent chemotherapy for this patient. And so let's change gears now. That was hormone receptor positive, HER2 negative disease. Let's talk about patients with HER2 positive disease. The Destiny Breast 03 study showed a benefit in progression-free survival of trastuzumab deruxtecan over T-DM1, which had kind of previously been our second-line go-to. So we see a hazard ratio of 0.33, so pretty clear benefit there. This did also translate to improved overall survival in this patient population. So talking a little bit more about T-DXd, which we also discussed in the hormone receptor positive setting, it's worth looking at the toxicity profile. Notably, T-DXd had higher rates of leukopenia, GI toxicity, and alopecia, which would not be expected as much with the T-DM1. So that's something that's important to counsel your patients on. And then this kind of elephant in the room with this drug is the risk of interstitial lung disease. This occurred in 10.5% of the patients in the T-DXd group. The majority were grade 1 or 2 events, but there were 2 patients who had grade 3 events, severe symptoms or oxygen indicated. None were deemed grade 4 or 5. The median time to onset of ILD was 168 days, but you can see that there was a very wide range there. And so in the clinical trials, patients were required to have a CT chest every 6 weeks for interstitial lung disease surveillance. This is kind of between their scans to reassess treatment response. So I am incorporating that into my clinical practice because I think the risks of missing interstitial lung disease are actually quite high. If you have any clinical or radiographic suspicion for ILD, you should suspend the T-DXd, promptly initiate steroids, and consult a pulmonologist. So I think in deciding how to move forward in the second-line setting for these patients, we don't really have any data to understand how T-DXd compares head-to-head with capecitabine, trastuzumab, and tucatinib, another commonly used regimen in this context. So I would typically make those decisions about which of these regimens to go with on the basis of ILD risk. Do they have any underlying cardiopulmonary disease that might kind of steer me away from T-DXd? Alopecia, which is going to be much higher with T-DXd, so if that's a concern to the patient, I might preferentially reach for the CAPE and tucatinib regimen. And then if a patient has CNS disease, I would typically prefer to use the capecitabine tucatinib regimen first. I think the reality is all of these patients are likely going to see both of these regimens. It's just a matter of which one is second and which one is third, but that's kind of how I make my decisions. And so just very briefly, let's talk about triple-negative disease. There have not been a lot of major changes in this space in the past year. In the first line, I continue to use chemotherapy with or without pembrolizumab, making the decision about the pembrolizumab on the basis of the PD-L1 status based on the Keynote 355 study. In the second line, I would typically reach for chemotherapy or possibly sacituzumab. Again, if they had a prompt recurrence after their curative intent chemo, then that curative intent chemo would count as a line, and you could consider giving sacituzumab in the second line. If not used in the second line, I would reach for it in the third line. You could consider trastuzumab deruxtecan in these patients. Triple-negative disease was included in the Destiny Breast 04 study, but they were really a minority of that study. Most of those patients had hormone receptor positive disease. So it's nice to have another tool in the toolbox, but I would kind of put that lower on my list of therapeutic options for these patients. We do have a clinical trial open for patients with triple-negative metastatic breast cancer. This is a study looking at sacituzumab with or without pembrolizumab in patients who are PD-L1 negative with triple-negative breast cancer. So they would not be eligible for pembrolizumab per the standard of care in combination with chemo, but on this study could potentially receive it. So I like this study. Patients have to be treatment naive, but I like the opportunity to potentially get access to immunotherapy for PD-L1 negative disease. And then I also like that it moves sacituzumab up to the front, where people can qualify for that earlier than they can in the current context. So patients have to be willing to undergo 2 biopsies if safely accessible. So please, if you have patients who you think might be eligible, send them our way or shoot me a message and we can take a look at things before starting their first-line therapy, because once they've started another therapy, they are rendered ineligible. So I have tried to include references throughout the talk on the slides, but here's a summary of the references that were used in this presentation. And again, I'm so grateful for the opportunity to talk with you today and happy to answer any questions that come through. So thank you again.
Dr. Ray, thank you. This has been wonderful and very comprehensive. Let's see. So just a reminder to our audience that you can go to that same polev.com/UNCLCN or just put in UNCLCN. And now's your opportunity to anonymously share questions with Dr. Ray. Let me see if we don't have any in yet, but we're just starting that. So let me ask, you mentioned specifically with Elastra, with Elasestra, the greater nausea and vomiting. Any related to that, any updates or advances in terms of managing side effects?
So I think using antiemetics fairly proactively would be important for these patients. That's really the primary thing that I would do. And again, I'm pretty eager to see, they did collect quality of life data as part of this study, and I'm interested to know whether that increase in nausea and vomiting, clearly impacts quality of life for patients. You would think so, but sort of how you balance the improved efficacy against the worsened toxicity, I think, is something that we as clinicians have to wrestle with, and our patients need to consider. We need to listen to the patient voice in making those decisions.
Absolutely. Thank you. We'll keep waiting for a couple of more minutes to see if more questions roll in. As you noted at the beginning, it's been way too long since we've had you here or this topic. What's on the horizon? If hopefully we'll revisit this topic in about 1 year and not longer. But what do you think you would be speaking to if you were to rejoin us in 12 to 18 months?
Yeah, it's a great question. I think the sequencing of therapies is always something that's moving in breast oncology, and so some of these therapies that are approved for use further down the road may actually begin to move further up in the line. That's probably one of the biggest things that I would expect to see in the future.
Great. Thank you so much. And a question just came in. There is toxicity and AE associated with new cancer drugs. Is there any off-label usage happening? Thank you so much for that question.
Yeah, thank you for that question. I think, the reality is that most payers require us to stay pretty by the book these days, following national guidelines and following the FDA indications for drugs. So off-label usage, I guess, is pretty infrequent, unless you can really make a case for why you need to deviate from the standard of care. But we are constantly trying to balance, especially in the metastatic setting, efficacy, improved outcomes in terms of progression-free survival and overall survival against the toxicities, because all of these therapies are palliative and not curative. So that's really important to try to preserve quality of life. Yes, so there was sort of safety signals with combining tamoxifen and abemaciclib with increased risk of VTE. So we know that each of those drugs carries a VTE risk. In terms of sort of prospective trials that have explicitly looked at the subgroup of patients on tamoxifen or abemaciclib, they very well may be out there. I just am not as familiar with those data. But I think the signals from the Monarch-E study were pretty compelling, that avoiding that combination is important for our patients. It can be a challenge if you had a premenopausal patient who then has cessation of menses with chemo and you're not really sure whether their ovarian function is going to resume. Historically, we've put those patients on tamoxifen and sort of waited to see whether their ovarian function resumes before we just automatically put them on ovarian suppression, which may not be required. But I think if I had a high-risk patient in whom I wanted to use abemaciclib and they were premenopausal, I would go ahead and reach for the ovarian suppression plus AI.
Thank you.
Yeah,
go ahead.
and then the next question about the sacituzumab pembrolizumab trial, so common side effects of this regimen. So the trial will collect data on adverse effects, including people who are receiving both drugs in combination. So that is yet to be determined. But one kind of other appealing thing about this study is both of these drugs are FDA approved in other contexts. It's just the novel aspect of the trial is their potential combination. And so we typically, in partnership with our clinical pharmacists, counsel patients on the risk of each of these individual drugs, but we still don't know a lot about the safety of combining them.
Great. Thank you so much. And what I'll do, I'm going to leave since we have a couple of more minutes, I'll leave the polling open. I'm going to move ahead and do some of our thank yous, and then we'll go back if we get any additional questions that come in. I do want to say thank you to everyone in North Carolina for their generous funding of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. Specifically on the UNC Lineberger Cancer Network team, we want to thank Veneranda Obore and John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, and Patrick Muscarella, who are always busy making sure that these lectures and so much more is available.